He also did a postdoc fellowship as well in the research and progenitor cell therapies for the treatment of central nervous system diseases. And he also completed a fellowship in cardiothoracic surgery at MD Anderson as well. He's an assistant professor in our department. He's also an associate program director for a fellowship program. And he's been very well involved with education, with medical students and fellows overall. He is a great friend, a very good partner, and then it's our pleasure and our honor to have him today here in our lecture. Well, welcome, Dr. Hetz.
Thanks, Juan. So my talk is give me what I need, not what I ask for, a potpourri of surgical instruments in history. The origins of this talk were actually were my chief resident lecturer for Grand Rounds. I gave a similar talk, and it seemed to go over pretty well, so decided to kind of tailor it a little bit more towards cardiothoracic surgery, and that's sort of the story behind it. I think the newer generation, myself included, of surgeons don't really appreciate the history as much as the previous generations have, and so a lot of times we ask for instruments but don't really know the history behind them. So I'm hopeful that this lecture will sort of help with a little bit of that, or at least maybe pique a little bit of interest in learning about the history of surgery. I have nothing significant to disclose. So if I've seen, I love this quote. I think this is a great quote for many things, but specifically for surgery. If I've seen further, it's by standing on the shoulders of giants. This is a quote from Isaac Newton in 1676. But kind of like this talk, he didn't get it from himself. It was originally from John Salisbury in 1159, where he said, "We are like dwarfs sitting on the shoulders of giants. We see more, and things are more distant than they did, not because our sight is superior, but because we are taller than they, but because they raise us up, and by their great stature add to ours." And like many, many things, it comes really from the Greek mythology of Orion, who was blinded and placed the child on his shoulders, and this child led Orion to the rays of Helios to restore his sight. And so much like surgery, we are, just like this in surgery, we really are lifted up by the people that trained us, and the greatness of each generation is really due to the greatness of the previous generation. And so here's a picture of that. This is Dr. Safi, who I think has lifted many, many people up in this department. He is the giant whose shoulders we look upon, standing next to his partner, not his partner, but his mentor, Dr. DeBakey, standing right over his shoulder, coincidentally. I also included this slide.
My God, don't say that. His partner, my God, he's the God. You don't.
I said your mentor, I corrected myself, but my favorite part of this slide is not just that picture, but also that Dr. Safi's only been active for 40 years. I just want to point that out. So despite his age, he's only been active for that many years. In any case, we'll start the instrument portion of this talk. Give me what I need, not what I ask for, which is for the non-surgeons in the group, sort of, sometimes a little joke we say when we can't remember what we asked for something, but we really meant we wanted something else. It's a pretty common phrase. So I'll start with the Kocher forceps, or the Kocher clamp. Originally, this is designed as a hemostatic forceps to catch bleeders deep in the tissue. And it was designed for hemostasis in thick tissue, lightly with origins from thyroid surgery, as we'll learn about Dr. Kocher, who's a thyroid surgeon. And today, though, unfortunately, it's mostly used for holding fascia, and sometimes in my world for grabbing bone as well. The instrument was designed and named after Emil Theodor Kocher, who you can see lived from 1841 to 1917. He's a Swiss physician, and in 1909 won the Nobel Prize for Physiology of Medicine for his work with the thyroid. He's the first surgeon to win this prize, though not the last, and was a strong proponent of aseptic technique. His major contribution to thyroid surgery was for the treatment of goiters. And in 1972, thyroid surgery carried a 75% mortality. So a higher mortality pretty much than anything we currently do. Nobody would do surgery today with a mortality of 75%. And using his aseptic technique and meticulous surgical techniques, he was able to decrease that mortality to less than 1% by 1912. And with his expert removal of the thyroid gland led to the discovery of cretinism and congenital cretinism due to the lack of thyroid hormone. And this discovery is ultimately what led to the use of thyroid hormone replacement therapies for various thyroid diseases. He's got many other things more than just what are listed here, named after him, namely the Kocher maneuver to expose the retroperitoneum, the Kocher incision, the right subcostal incision, and the Kocher point, which is a common entry point for intraventricular catheters for the placement of CSF drainage. The next instrument to talk about is the Babcock forceps or clamp. This was a forceps designed to gently grasp the bowel without compressing it or causing injury. It's named after and designed by William Wayne Babcock. He was a New Yorker. He received his MD from the College of Physicians and Surgeons in Baltimore in 1895, and then received a second MD from the University of Pennsylvania. I think medical education, obviously in this time, was significantly different than it is today, but not 100% sure why he needed 2 medical degrees. He was the chair of surgery at Temple University and taught there for 45 years, and he also authored the textbook Principles and Practices of Surgery, which was really the authoritative text in surgery through the 50s and 60s, and then pioneered the use of spinal anesthesia and stainless steel sutures in surgery. Similar to the Babcock is the Allis Clamp. I think a lot of us will ask for this in surgery, not just for bowel surgery, but it's an atraumatic tissue forceps used for gently grasping bowel and often used to facilitate a bowel anastomosis. Oscar Huntington Allis is the inventor of the clamp and who it's named after, and he's a New Yorker, best known for his work in orthopedics surgery, known for the Allis sign for femoral neck fractures. He also invented an ether inhaler named after himself for anesthetic. Though he's best known for orthopedic surgery, he developed the Allis forceps to perform bowel anastomosis when the Murphy button failed. So I decided to talk about the Murphy button as well, even though it's not really in the realm of cardiothoracic surgery currently. But this was, I thought it was interesting. It's a button that was used for small bowel anastomosis to do a sutureless anastomosis by approximating the bowel in an end-to-end configuration. The issues with this were it narrowed the lumen and caused necrosis at the anastomosis. But we all know we've all heard of Murphy with the Murphy sign. So John Benjamin Murphy was an American physician from Wisconsin. He was an early proponent of appendectomy for appendicitis, and in 1912, he was the surgeon that cared for Theodor Roosevelt at his attempted assassination. And like we said, he's known for Murphy's sign, the right upper quadrant tenderness with acute cholecystitis, as well as a Murphy's punch, the CBA tenderness with perinephric abscess. So now we're going to more delve into the cardiothoracic and vascular surgery world for at least a moment with the Crafoord Clamp. This is named after Clarence Crafoord, who was a Swedish surgeon whose first was the first to surgically correct coarctation in 1944. He also was the first to implant a pacemaker in 1958, and the first to use heparin for sorry for the typo, for chemical DVT prophylaxis in 1935. And again, a clamp that we still use today in vascular and cardiac surgery. The Satinsky Clamp is the next clamp that we often ask for, but not sure we know the origins of. And this is named after Victor P. Satinsky, who's an American surgeon from Philadelphia. He joined the U.S. Army for World War II and was responsible for at least 30 medical innovations. Wasn't a lot more about him aside from that I could find. And then the next is there are Potts scissors. Potts scissors, obviously, for cardiac and vascular surgery are incredibly important, and they're not named after John Rex Potts. I think Dr. Safi will get that joke. And they're named after Willis Potts, who is an American surgeon. he was involved in both the world wars and was predominantly a pediatric surgeon, and was also famous for the Potts shunt for palliating tetralogy of Fallot babies. And this was a shunt where he would sew in a side-to-side fashion the left main pulmonary artery to the descending aorta to palliate these babies, and was actually fairly successful, and was for some time actually used over the BT shunt because of less issue with it. But like many things with shunts, it had problems with people making it too big or too small. He really the reason they say that he invented the Potts scissors and the Potts instruments were because he was a fairly large man, and doing delicate surgery on babies needed finer instruments so that he could perform those surgeries. And then sort of in the opposite direction, the Metzenbaum scissors are obviously the scissor I think that we use the most in our practice. And they're made by Myron Metzenbaum, who was an American surgeon and mostly known for being an otolaryngologist. He created a city-run ambulance service in Ohio because when he went to medical school, he actually was asked to live in the hospital in order to help be available for emergencies to help with anesthesia. Metzenbaum was known to have very small hands and had difficulty manipulating standard instruments, so he designed these finer scissors that are basically used in every surgery today, really to facilitate him taking out tonsils was the main reason these were invented. The next will be the Doyen Rib Raspatory, or the Doyen kind of rib like periosteal elevator, and these instruments are very specific to thoracic surgery and usually used when we're doing a rib resection or to harvest an intercostal muscle flap. And they're used, I don't know how familiar everybody is with these, but they're used to get around the rib and dissect the neurovascular bundle free of the rib without causing injury to the bundle, but they definitely can be fairly bloody. And these were developed by Eugene L, who is a French surgeon. He claims to have successfully cured cancer with electrical treatments and was among the first surgeons to use electric coagulation in the surgical field. He was also the first surgeon to ever use suction in the operative field, and one of the first surgeons to film his operations and show it at conventions, which, as you can imagine, in this time, was a lot of people didn't like that and felt that it was unnecessarily flashy. Next is the Finochietto Retractor, which is a retractor that is certainly used in thoracic and aortic surgery as well to spread the rib spaces. It was developed by Enrique Finochietto, who's an Argentinian surgeon, the son of a well-known surgeon as well, who trained in Europe and the U.S. at the Mayo Clinic. He was the chief of surgery at Rawson Hospital, where he lived like in-house, sort of like Dr. Duke, to be on hand for emergencies. And he's the inventor of at least 67 surgical instruments. In 1936, he invented the Finochietto Retractor after making some modifications to the Tuffier Retractor. And in 1929, performed the first cardiac intervention in Argentina, repairing a bullet wound to the heart. And he died of syphilis at the age of 66. Tuffier Retractor is another rib retractor. The issues with this and why it was modified was that the rack and pinion sort of action of it made it great for spreading open the ribs, but it would also quickly be released if there was any tension. It was created by Theodor Martin Tuffier. He's a French surgeon who's responsible for the first successful resection of a right upper lobe destroyed by tuberculosis. He worked with Alexis Carrel, helping perform one of the first successful interventions for aortic aneurysm and help with the first dilation for aortic stenosis. I tried to actually look up the papers to see exactly what they did for the aortic aneurysm and for the dilation of the aortic stenosis, but they were in another language and they were not available. So the next one is a Foerester Clamp. This is the sort of a clamp that I don't think I could do VATS lung surgery without. This is a straight one. I usually use a curved one in lung surgery, but It goes by many names: a sponge stick, a sponge clamp, an empty curve ring. And it was invented by David Foerester, an MD, a plastic surgeon in Oklahoma, who's really known for being a gender reassignment surgeon. And even though I need this instrument for thoracic surgery, its most common use is body piercings, and specifically for putting in tongue rings. And then this is kind of a change of pace, but going to the Varus needle. And this is an instrument that we use to gain access to the abdomen. It's a spring-loaded needle with a blunt inner cannula that retracts as it meets resistance. It's the oldest known method to obtain access to the abdomen in laparotomy. The reason I continue to include it is that the origins are actually from Jonas Varus. He's a Hungarian internist who was focused on patients with tuberculosis, and prior to antibiotic therapy for tuberculosis, iatrogenic pneumothorax was a therapy choice, and he developed this needle to safely enter the chest and cause iatrogenic pneumothorax to collapse the lung to treat it. So even though we don't do this anymore for tuberculosis, it does have its origins in the thoracic world. And then I included the Hasson Trocar, mostly because I think the inventor looks like Dr. Khalil, but this is a trocar that we use also for laparoscopy in the abdomen, but it's a more controlled technique. And really, this is why I can truly, Dr. Hasson is an Egyptian-born OBGYN who practiced in Chicago. He claims to have done over 5,200 of these procedures with the Hasson, having only 27 complications, and one being a bowel injury. But I don't know if it's just me. I think this picture looks a fair amount like Dr. Khalil, who's also an Egyptian-born physician. Next, probably my favorite thing that I learned about from doing this talk was the Weitlaner retractor, and it's not a Wheatlander, which most people say. It's a self-retaining retractor used for virtually every surgical specialty, and it's correctly pronounced Weitlaner. It was made by Franz Weitlaner in 18... Say that again? It was made by Franz Weitlaner, an Austrian physician born in a German-speaking municipality in Italy. In 1905, he published a description of his retractor in the Vienna Clinical Review. In another review, he touted the superiority of this retractor over the Bras wound dilator, which I guess is true because I've never heard of the Bras wound dilator, and I've definitely heard of this retractor. The retractor was very successful, selling for about 20 marks, which is about $175 in today's economy. But I think the thing that I think is at least funny about this, or at least kind of will give you a chuckle, is he took no money for the creation of this device, with the only deal that he would name the retractor. And so he called it the Weitlander Wunderspritzer. And in 2009, an article titled "Franz Weitlaner, the Great Spreader of Surgery" was published in the Journal of Trauma. And like I said, I think it's funny because the guy took no money for this, invention. He just wanted to name it. And I think that this instrument's the one that's misnamed the most of all the instruments. The next instrument is Castroveijo needle driver. It's a needle driver used in microsurgery. And I think Juan will agree with me. I like this because it doesn't really care if you're right-handed or left-handed. It seems to work equally well with both hands. And it was made by Ramon Castroveijo, who's a Spanish-American eye surgeon. His father was also a prominent eye surgeon. And while not the first to perform corneal transplant, he really did improve the technique to a point of universal acceptance as the treatment for corneal disease. So really a big contributor in the ophthalmology world. So that kind of ends the part of the talk about surgical instruments. I guess I'm kind of flying through this talk, but I included some pretty common, not common procedures, but procedures that I feel like commonly get discussed in our M&M conference. And that's because a lot of times, we'll perform, I'm going to do air quotes, a Bentall procedure, and the resident will present this, and Dr. Safi will really hammer them because it's not a real Bentall procedure, what's being presented. So I just sort of wanted to go over the procedures, the history, and the modifications to help kind of, I guess, help everybody out, at least for the next year or two, until the next group of fellows comes. So the Bentall procedure was designed to replace the aortic valve, aortic root, and the ascending aorta, and it was described by Hugh Bentall and Anthony De Bono in 1968. Nearly 10 years after DeBakey and Cooley described the first ascending aorta replacement. And it was performed on a 33-year-old man who had severe AI and a dilated root and ascending aorta. And he was actually diagnosed by his wife after she heard a very, very harsh murmur while laying with him in bed. This is a picture from the actual paper describing their technique. And I think their initial intention was just to replace the ascending aorta and the aortic valve, but when they opened the aorta, the tissue was so friable that they knew that they couldn't sew to the aorta. So they instead took a star valve, sewed it to a Dacron graft, and then sewed the graft into the, sewed the valve into the annulus, and then opened some holes in the graft, put their perfusion cannulas through those holes, and then in an inclusion technique, sewed the coronaries to the graft. And this is, I think, where most of the fellows get it wrong when they say that what they've done is a Bentall procedure, because the way that these coronaries were implanted is much different than we ever do today. We never do this today. And the graft was then, once this was done, the graft was then, the distal was done, and you can see a slit on the hole number 5 was left in the graft for those coronary perfusion cannulas. This was closed, and then the native ascending aorta was trimmed and sewn back over the anastomosis. And this is done because this Dacron wasn't albumin impregnated, and so these grafts weeped quite a bit after surgery. I mean, as much as 100 to 600 cc's per minute of blood would come out of these, and so this was done to decrease the bleeding, sort of like a Cabrol patch, which we'll talk sort of about in a moment. But the problem with this is that this would put undue tension on the coronary anastomosis, causing late pseudoaneurysm formation and bleeding. So Hugh Bentall is a bit more modern surgeon, died in 2012, is a British surgeon, and in 1959 traveled to Moscow to demonstrate open heart surgery on 5 patients to over 200 surgeons, and is obviously has big contributions to cardiac surgery. This is, early in the world of cardiac surgery, with the cardiopulmonary bypass machine being invented or utilized just a few years earlier. And then there's the Bentall modifications. There's the Cabrol modification, the Kouchoukos modification, and the Svensson modification. This is the Cabrol modification. And so again, another thing that we talk about in our M&Ms is somebody will say that we reconstructed the coronaries with a Cabrol, and again, it's something we almost never do in in our time now. And the Cabrol modification was very similar, where the aorta was kept in situ and sort of with an inclusion technique, but the coronary anastomosis was done by sewing a single Dacron, like an 8mm Dacron graft, to the left coronary ostium. And then once the anastomosis of the aorta was done, the right coronary was sewn to, and then a single orifice was made in the graft to sew the coronary to sew the graft to, and then just like in the previous Bentall, the native aorta was closed over top, but a fistula was made between the right atrial appendage and the native aorta to allow the blood that's leaking out of the out of the graft to go back into the right atrium to hopefully decrease tension on the anastomosis that was created, and really was I think a very, very smart technique, and something this is essentially the Cabrol shunt that we do today when we have severe coagulopathy after type A dissections or any kind of Surcar-esque case. So Christian Cabrol is a French cardiac surgeon who performed Europe's first heart transplant in 1968. Europe's first heart-lung transplant in 1982, and Europe's first Jarvik total artificial heart in 1986 as a bridge to transplant. He was a Fulbright fellow going to Minnesota to train with Walton Lillehei. At the same time, he worked with F. John Lewis, who's known for being the first person to perform open heart surgery in 1952 for an ASD repair. Christian Barnard, who's known for being the first person to successfully perform a heart transplant, and Norman Shumway, who's also well-known transplant surgeon, the first person to do a heart-lung transplant. So a lot of firepower in Minnesota at that time. The next thing I'll talk about is the Kouchoukos modification, who I think Dr. Safi thinks is probably, I'm at least guessing, would say is probably the most important, kind of modification that they made to help with these types of surgeries. And this isn't in Kouchoukos' paper where he describes his technique. This isn't really exactly. This isn't taken from his paper, and it isn't exactly what he talked about. The paper was kind of over a series, and near the end, the big change was that the Dacron graft, he then soaked it in albumin and then put it in an autoclave at 250 degrees to cook it in and to basically decrease the permeability of the graft, and that did away with this leaching of blood through the graft, and so allowed him to not do an inclusion technique, but doing what they called an open technique. And in many of the first iterations of this, he did do this sort of inclusion coronary anastomosis, but found as he went on that doing kind of a Cabrol button was a better technique. And actually later on, Kouchoukos published the button Bentall, is what he calls it, where the coronaries were reimplanted by taking a rim of aorta along the coronary ostia and sewing that to the aortic graft. But really the big advantage was impregnating the graft with albumin to keep it from bleeding. There's not much about Nicholas Kouchoukos. He's still alive. He trained in general surgery at Washington University and then did his CT training at UAB. He stayed there for about 14 years and then moved back to Wash U, where he was there for about another 12 years, and then went to, I think, Baptist Hospital in St. Louis, where he ultimately retired as a professor emeritus. And then the last one I'll talk about is also a little bit of a dig at Dr. Safi, because if I'm not mistaken, I think Dr. Safi was probably the originator of this technique, but never published it. And Dr. Estrella never lets him forget that. So I'm going to call it the Svensson modification, because Lars Svensson did publish it. And in this modification, it's really a modification to the Cabrol, where the left coronary artery is sewn to an 8 to 10 millimeter Dacron graft, and then wrapped around the front of the aorta. The right coronary is sewn in the button technique, and then the left coronary is then sewn to the front of the Dacron graft. And this is beneficial because it takes any tension off the left coronary anastomosis, and also allows good visualization of all potential bleeding sites, so that so any bleeding can be repaired. I don't want to say easily, but much more simply. And Lars Svensson's a South African cardiac surgeon who's the current chair at Cleveland Clinic. He trained in Houston, Texas, and Baylor College of Medicine in CT surgery, as well as an additional fellowship at Cleveland Clinic. And he was a contemporary of Dr. Safi's at that time. And then I'll end this with this sort of a primer. It's called How to Swim with Sharks, and this was a guide for swimming with sharks. It was written in the late 1700s and early 1800s by Voltaire Cousteau. Little's known about the author, but it's said that he wrote this as a guide for sponge divers, but it seems to parallel surviving surgical residency. It was originally introduced to the world in 1975 in the Transactions of the Association of American Physicians, but was reprinted in the Thoracic Surgery Clinical in 2011, and I believe reprinted more recently in 2019, and simply lists the rules for swimming with sharks. Rule 1, assume all identified fish are sharks, unless you have witnessed docile behavior in the presence of blood or bloodshed or more than one occasion. If bitten, do not bleed. Bleeding prompts more aggressive behavior. Lack of bleeding will confuse the shark and make them question their own potency and believe the swimmers to have supernatural powers. Counter any aggression promptly. Sharks rarely attack without warning. When early aggressive behavior is encountered, make an appropriate counter move to make it clear you understand the shark's intentions and are prepared to do whatever force necessary to repel the aggression. And get out of the water if somebody's bleeding. Blood in the water can provoke attacks from uninvolved swimmers. Use anticipatory retaliation similar to the Rule 3, but use when provoked. Use this with caution. And 6, disorganize and organize attacks. The proper strategy is diversion. Introduce something minor or trivial that will get the sharks fighting amongst themselves. And by the time the internal conflict is settled, they'll forget what prompts the attacks in the first place. I don't know. That last one just really reminds me of our old M&Ms when we would be in person and Safi and Eisenberg would go at it, and the resident up on the podium would get out of harm's way for that reason. So thank you. And I'll take any questions or any commentary from Dr. Safi as he's lived through a lot of this. I can now.
Yeah, the most important thing that the typical academia that Cabrol, I mean the other guy, a friend, the Englishman who visited Sterling Edward in Mobile, Alabama, and saw the first recruit replacement. He went to England without giving him a credit. That's told to me by Dr. Crawford, so I don't know whether that's true or not.
Did I get the modifications right, Dr. Safi?
Well, yeah, and actually, Tony always for not publishing, but at that time I was busy. It's good. I'm not big in the names. You can put any name you want. Most of the names would be forgotten within a generation. So, now Lars Svensson is a superb surgeon. He was, he trained in. He's a Swedish citizen as well as a South African citizen because his father was, I think, Lutheran preacher in Soweto. So he had two services in the Swedish Army and South African Army. And he joined us as a fellow, and subsequently he did his thoracic training in Baylor in the department. It didn't last long because Dr. Crafoord had a stroke, and he went to First Lady, subsequently to Cleveland Clinic. He's doing a great job. Great photographer.
Dr. Safi, what do you think about that final advice from Dr. Hetz?
Well, I'm not big on advices. I mean, advice is advice. It doesn't mean damn thing. In reality, you can. What's the last one? I forgot. What's the last one? What's the last advice? Can you hear
organize
me?
attacks and divert the attention, Dr. Safi, to divert the attention from the conflict.
Oh yeah, it's good. Yeah, diversion is good, but you need to read Art of War and before you understand that.
Anyhow, Bob, I think it was a great lecture. I'm a fan of history of medical stuff as well. So I commend you for finding the original drawings of these techniques and all that, and very delighted. I really enjoyed it very much. Thank you for the topic.
Thanks, Juan.
Great job. Great job. Thank you.
Thank you.